All right, I'm going to go ahead and kick us off. I know that people are still jumping on, which is great. This is being recorded, so if there's anybody that you know that wasn't able to join or was able to join late, it will be posted online after the conclusion of the meeting. So I'm going to go ahead and kick us off today. My name is Candace Bailey. I am the HCBS Division Director, and I am here to continue our discussion for the Nurse Assessor Program, which will be launching this summer. Next slide, please. All right, so just a reminder to ground us in our mission. It is improving health care equity, access, and outcomes for the people we serve while saving Coloradans money in healthcare and driving value for Colorado. Next slide, please. Meeting purpose. So the whole point of this meeting is really to continue our discussion and provide information to you all, our stakeholders, around the Nurse Assessor Program itself. Next slide, please. All right, so agenda. So real quick before I dive really deep into the meeting here, want to let everybody know that today we are going to try something a little bit new when it comes to the chat. So please go ahead and submit your questions and all of the things in the chat. The team is really going to work hard on capturing those questions. And then when we see things that are coming up multiple times, so when there's a theme of several people asking the same question, they're going to flag it for me to answer live. And the reason for this is to make sure that everybody gets the same information. It also allows people to focus on the presentation itself. A lot of the questions will be answered throughout the entirety of the presentation. And when you have to follow both the slides, me talking, and read all the chat and all the responses, it's really hard to follow both. And so we really want to give people an opportunity to focus on the meeting today, focus on the presentation. We will be capturing every single question. We will post it just like we did last time as well with responses. But just so you know, when it comes to questions specifically around the Nurse Assessor Program, the team is not going to be answering those in the chat. They're going to capture them for us to answer later. If we do see the same question several times in a row, they will flag it for me to make sure I answer it live. We will have time for some questions too today to go through. We lengthened this meeting because we know that last time with all of the questions, it was not enough time. And so there will be time today to answer several questions as well. But just wanted everybody to know that that's the process we're going to use. Technical questions around the slide deck and things like that, the team will make sure those links and everything are posted. Okay, so with that, I'm going to go through our agenda. So we are going to recap our last meeting. We'll go over the things that we heard and make sure you all have access to all the resources that are available. We're going to go real brief, high-level overview of the nurse assessor process, walk through some actual scenarios of how it's going to look. So as a member seeking long-term health, for example, we're going to walk through some examples so it's much easier to follow the process. And then we're going to talk about the appeals. We received a lot of questions on appeals. So next slide, please. All right, so a quick recap of the last meeting. These are some things that we heard that folks wanted more information about. Who is the vendor going to be? Folks were asking for the scoring rubric for the assessment tool. What does the appeals process look like? When can somebody appeal? And then the actual process itself for how case managers are going to communicate, how the referral process, all of those things. So we heard a lot about that. And so I'm going to actually walk through several of these. But before we move on, I'm happy to announce we are actually able to announce who the vendor is, who the contract will be awarded to. We are in the process of negotiating that contract and working through that right now. But we can let you know that Telegen is the vendor that successfully bid on this program, and we are working on securing a contract with them right now. So that's very exciting. And then the scoring rubric for the assessment, we actually had to get that. It's a process to get everything accessible. So the reason why it took a little while to get that up and running was for accessibility reasons. So that is actually now live and posted on the website. So you can see the assessment tools and the rubric as well that goes with it. So that's really exciting. So that is all posted. That is all on the website. And then, like I said, we're going to go through some of the referral processes throughout the slides here. Here are some actual resources for you all. I'm sure folks will be posting them in the slide deck or in the chat so you can access them. She can't click on them when we're presenting, unfortunately. But there's a webinar recording from last month, the listening log. So all of the questions that we had that came in via the chat, and then also some of the email questions that we had after the fact, we posted in the listening log with responses. So that's all live and online. And then the Nurse Assessor and Skilled Care Acuity Assessment website. So that website is live as well, which talks about the Nurse Assessor Program and then also the Skilled Care Acuity Assessment. So all very exciting there. Next slide for me, please. All right. So a quick little recap of what the Nurse Assessor Program is and why we're doing it. So it's really a process to streamline the way members are assessed and to receive a recommendation for skilled care services. What will happen is the member is going to be assessed using a third-party vendor, and this is actually going to reduce the duplicative assessments that have to be done and the duplicative authorizations that could be done. So this will be one assessment by the nurse assessor versus potentially 3 different assessments by 3 different providers, if you will. So if you have a provider that only provides CNA services, you have a provider that only provides nursing services, and then potentially if you also mix in PDN in there as well, that would be 3 different providers with 3 different assessments. This is actually going to streamline that, and there's going to be one, which is really exciting. The idea is also it's going to provide some education to members on the front end. So helping everybody understand how their needs can be met and the different options that are available. So not everybody is aware of the self-directed options that are going live for all of our CFC members, so children and adults, that will be effective July 1. And this is a really good way to make sure everybody has that education so that they can choose the way that they want to receive their services. So it's really exciting. And it's just, really it's a holistic assessment of the member's need for skilled services. So looking at everything all at once. Next slide, please. This is a really wordy slide, so my apologies, but it was really important so that everybody could see the differences here. So these are the services that the nurse assessor is going to be reviewing. So it's private duty nursing, long-term home health, which is both the CNA services and intermittent nursing, and then health maintenance activities, which are the skilled component of self-direction. And so here's the definitions and information about what each of these are. I'm not going to read them all to you because that is very boring and nobody wants that. But you all have this information. Like I said, the slide will be posted, but it kind of gives you an idea of the differences between the services, but also these are the ones that will be assessed. Next slide, please. And then here is the high-level process. We went over this last time. You have the referral, the intake call, the assessment, and then the recommendation. So the referral can come from anywhere. We're not looking to make anything more complicated. We really want it to be any of these agencies, other people, if there's somebody we missed, obviously this is not an exclusive list here, can provide the referral. And then the assessor or the assessor agency will call the member or the family member to get more information. It would be helpful if, for example, a hospital or a provider agency is conducting the referral, that they can actually share the plan of care that they already have, any doctor's notes, things like that with the nurse assessor, so they have some of that information ahead of time. Super helpful, not required, but would be great for them to do that. And then once they conduct the intake call, they will schedule the assessment. The assessment must be face-to-face. That means either a video conference call, depending upon the preference, or in person. And it will really depend upon the medical complexity and other criteria for whether or not it's in person or virtually. But it will have to be face-to-face, meaning there has to at least be a video connection. And then once the assessment is complete, the nurse assessor will create a recommendation. That recommendation will be sent to the family and or the member, both, the case management agency, and if applicable, and then the home health agency if applicable. Next slide, please. All right, so this is the PAR approval process. So one thing to keep in mind is we have the skilled care acuity assessment that is conducted by the nurse assessor. That is not the PAR process. That is not the prior authorization process. That is different and that is separate. And so for PDN or long-term home health, in the left-hand column, the blue, there's the process for getting the PAR approved. The home health agency must still submit the prior authorization, the plan of care, the recommendation letter from the nurse assessor, and any other related documents must go to the vendor who currently is a Centra. The center will then review all the documents to make a thorough medical necessity determination. So the PAR process, that is where the medical necessity determination happens for long-term home health and private duty nursing. And that is the same process that exists today. A center will then provide an approval or notice of a denial or partial denial and appeal rights. So that is the process that exists today. That is the process that will exist on July 1st and going forward. So that is not changing. For health maintenance activities, what will happen is the case manager will review the recommendation and the IHSS agency care plan, if applicable. And the case manager will then review the need for CFC or HCBS waiver services, depending upon the request and the members, all of their needs, not just their skilled care needs. And then they will provide a PAR approval or notice of denial, partial denial, and appeal rights. So again, the case manager completes the prior authorization. The case manager provides any appeal rights that would be necessary as well. Same process today, same process July 1st. The only difference really in these processes is that the case manager and the home health agency will each have the recommendation letter to be utilized in creating the PAR. Next slide, please. Okay, so we're going to go through some of these scenarios here. I have 4. I have 5. Just kidding. I have 5. So we're going to walk through some of these scenarios that I'm hoping are going to be helpful in providing context of how this is really going to work. How is this going to work on the ground? How is it going to look? And then once we get through the scenarios, I'd like to pause and take some questions from folks. All right, so scenario 1, pediatric long-term home health. So as you can see, Jamie is an 8-year-old with autism spectrum disorder. Jamie currently receives 4 hours of long-term home health from a CNA through a home health agency to help with bathing, dressing, meal prep. The agency sends the referral to the nurse assessor. Great, all is going well. Jamie and her mom schedule the time to complete the assessment. And then once the assessment is completed, the nurse assessor found that Jamie's needs are not actually skilled care needs. So what they're saying is that her needs would be more appropriately met under the Community First Choice program utilizing personal care or homemaker. The key here is that Jamie has those needs. Those needs are very clearly documented, but they don't need to be performed at the level of a certified nursing assistant, a CNA, that the scope might actually be personal care or homemaking tasks. And Pam, just one second, I'm going to get through a couple of these scenarios before I take questions. So then the nurse assessor sends the referral to the case management agency based on where Jamie lives. So those are regional. The case management agency will then assess Jamie for the level of care in order to determine if she is eligible for CFC or a different waiver. And if Jamie is found eligible, she will be assigned a case manager who will work with her mom to set up services and complete the direct care calculator to determine service hours. So this would be the non-skilled care hours and services that could be set up by the case management agency directly. So this is an example of a child who was receiving CNA services while the medical necessity review was off to determine whether or not the services are appropriate. Now that everything is coming back online, the nurse assessor conducted the assessment to help guide and show where the services are going to be most appropriately met. It is not always CNA care. It often is, but not always. And there are other available options under CFC for Jamie going forward. Next slide, please. All right, health maintenance activities, HMA. So Charlie is a 35-year-old individual who just moved to Colorado. Charlie has spina bifida, paraplegia, epilepsy, trouble swallowing, and oxygen dependence. So there's a number of different things going on. He requires assistance with transfers, ADLs, and a couple of other items. He has not received any services yet, so new to the state, but has been approved for Health First Colorado. So that's a really great first step. He begins by reaching out to a home health agency to get services started. The home health agency realizes that Charlie has not been assessed for skilled care services yet and makes a referral to the nurse assessor to begin the process. Charlie meets with the nurse assessor, goes through his needs, describes his needs, and how he received his services in other states. He tells the nurse assessor that he prefers to have his wife continue to provide his care. So this is really important. Charlie's new. Charlie probably doesn't know all of the options within the state of Colorado. In the other states, he had his wife providing his care, and that is clearly his preference to continue here in Colorado. At the end of the assessment, the nurse assessor is able to provide education on the different ways that Charlie can get his needs met, and including self-direction services. So that would be consumer direction or in-home support services, IHSS. Charlie decides that IHSS is likely the best option for him. So the nurse assessor is then able to send a referral to the local case management agency to help get Charlie set up with IHSS services. Once he's found functionally eligible for CFC, he is assigned a full-time case manager and receives a recommendation on the number of hours. The case manager completes prior authorization request, and then Charlie services begin. So you can see the process of how this would work for an individual newly receiving services. All right, next scenario. Cassie, do you want me to pause right here, or do you want me to keep going through the scenarios?
Let's answer this question live if we can, because I've seen it a couple of times.
Sure.
And what happens if someone's transitioning services? So in the first case of Jamie, she is being said long-term home health CNA services are not appropriate. They need to transition over to CFC for personal care. Do they continue those benefits? Do they go without during that transition period? What does that look like?
Yeah, so the nurse assessor recommendation is not an approval or denial. And what it is doing is it is providing the recommendation for the appropriate level of services, level of care for an individual. And also keeping in mind within the scope of practice, right? So understanding that they would not recommend a personal care provider provide services that are well within the scope of practice of a nurse and needs to be conducted by a nurse, because those are some really key factors there. So what they will need to do is the recommendations and the referrals need to happen prior to the expiration of a prior authorization or a certification, I should say, because they're not prior authorized right now. But they will have to happen prior to the certification ending so that Jamie will have time to set up those services within CFC prior to the CNA services ending. We're not looking to cut everything off. This isn't necessarily the best fit for you, and then services end in the next day. That's not how this will go. There are still going to be scenarios where the nurse recommends, 10 hours instead of 12. That doesn't mean just the 10 happens, because there's still an opportunity for the home health agency to provide the plan of care and the rationale and the reason why the services are medically necessary. And so there will be that transition time based off when the certification ends so that Jamie can have a chance to set up those services. Was there another one that you wanted me to answer, or keep going?
No, I'd say keep going.
Excellent. All right, next slide, please. Yes, slide 3, or scenario 3, slide 13, technically. All right, okay, so PDN. Amy is a 4-year-old who is reliant on central venous catheter for medications, a ventilator that requires oxygen titration, and an 11-hour overnight continuous tube feeding with intolerance issues. Amy has been receiving services since birth through a home health agency around 30 to 45 days prior to her PAR expiring. Her home health agency sends a referral to the nurse assessor to have the assessment completed. So this 30 to 45 days prior to the current PAR expiring, private duty nursing services are required to be prior authorized right now. That is a key time frame. So we want to make sure that the referral, and this is for the home health agencies, the referral goes over early enough to where the PAR can continue throughout the time of the assessment, and if any transition is necessary for that transition time period. The nurse assessor comes to Amy's house to complete the assessment in person. After completing the assessment and speaking with her family about their service options, they conclude that private duty nursing continues to be the most appropriate option for meeting her skilled care needs. The home health agency receives the assessment and service recommendation from the nurse assessor. So this is a scenario where child was assessed, determined the services at the level that she is receiving them continues to be the most appropriate level. The home health agency will then submit the recommendation letter, a PAR, the plan of care, physician orders, and then any other supporting documents to a center. So the idea is any other supporting documents. some children have a lot of documents, a lot of medical documents that the home health agency will have, and some will have two. And so the idea is you can submit nursing notes, seizure logs, all of the things should all go together with the recommendation letter and the PAR and the plan of care. After the medical necessity review is complete, the PAR is approved, and the home health agency can continue to bill for the services that are rendered. So this is a scenario that lays out a child that is currently receiving services, getting assessed, and then continuing to receive services, and then the processes that will take place during that time. So hopefully that helps with that one. Let's go to the next scenario, please. All right. Adult long-term home health. So John is a 67-year-old who lives in an ACF, alternative care facility. He gets insulin injections twice a day to help manage his diabetes, and there's a home health agency that goes to the assisted living to provide those injections. Prior to the expiration of his current prior authorization, his home health agency, again, the 30 to 45 days, please. I'm going to keep plugging that timeline. His home health agency will send a referral to the nurse assessor to have the skilled care acuity assessment completed. After the, that just changed my screen. So Kelly, you just added a read meeting note taker and it's messed with the whole screen. So I'm wondering if we can dismiss that. I'm going to keep going on my slide here. So the home health agency submitted the referral. The nurse assessor goes out and conducts the skilled care acuity assessment. The nurse spoke with John about his options. So letting him know that there are options that he can have to receive those services, the injection. And John tells the nurse assessor that he really wants to continue to using long-term home health. Great. Now he knows all of his options. The home health agency receives the assessment and the service recommendation from the nurse assessor. However, John and the home health agency do not believe that the nurse assessor recommended the hours to sufficiently meet his needs. The home health agency submits the recommendation letter. It's a letter with a number of hours that are recommended, a PAR for the hours that John and the home health agency feel are necessary and justified, the plan of care, the physician orders, and then the supporting documents that will help justify the need for additional hours to Essentra in order for them to complete the medical necessity review. Essentra conducts the medical necessity review and approves the requested hours. So the point here is that John's receiving services. John receives a recommendation that he and the home health agency don't feel like quite meet his needs. And that's okay. So that gives you an option and shows you the scenario of how that would work for this individual. All right, next slide, please. Okay, so real quick, I'm going to pause for anybody who's using an AI tool to take notes. I will let you know that this actually did cause some issues for us last time in posting our webinar and posting our slides and everything, the recording, because it actually provided a almost like a line by line note of it that kind of messed with the way that things were being recorded and posted. And so if there's a way to do it on the side, that would be more helpful so that it doesn't mess up with our posting and our recording of the webinar. That would be great. A lot of those AI things actually inhibit some of our ability to record some things. So just keep that in mind, please. Love all the new AI, love all the technology. Sometimes it's hard to work with. Okay, so did you guys move on? You guys did move on. All right, next scenario. So this is the last scenario that I am going through for today. And then we're going to pause. We're going to answer some questions and before we move on. All right, scenario 5, health maintenance activity. Katie is a 60-year-old with spastic dysplasia. She has been receiving health maintenance activities through Consumer-Directed Attendant Support Services, also known as CDAS, for many years. So Katie is scheduled for her continued stay review with her case manager. Her case manager sends the referral to the nurse assessor. at least 30 days prior to the CSR. Most case managers work much more than 30 days ahead. Most of them are working 60 to 90 days ahead. And so they will be submitting the referral to the nurse assessor on that timeline. And the reason why they're doing this is because Katie has reported skilled care needs through HMA under CDOS. The nurse will complete both the skilled care acuity assessment and the direct care calculator because Katie is currently utilizing CDOS. After the assessment is completed, the recommendation is sent to Katie and Katie's case manager, so both of them will receive a copy. Katie disagrees with the recommended hours. She contends that it does not actually accurately reflect the time that is needed for her skin care and dressing because of the braces and orthotics that she uses. Katie provides supporting documentation to her case manager justifying the need for additional time. With that support, the case manager is able to justify the time allocated for the PAR. PAR is then submitted and billing can occur. Point here is not everybody in the time frame that it takes isn't always the same for each individual. And as long as there's justification on the additional time that is necessary, then it can actually be authorized, which is really exciting. Okay. I've been seeing lots and lots of chat questions and comments pop up. Are there any themes that you want me to hit, Cassie? And then I'd like to open it up to folks, if possible, to ask live questions.
One question I think we've seen a couple of times is, can you talk about how does the agency get a feedback loop on here? If the information goes over to the nurse assessor, the member meets with the nurse assessor, does the recommendation letter just go to the member? Does the home health agency or case manager get a copy of that? How do they know what happens from there?
Great question. So the answer is yes, they get a copy. So the member and the family member will get a copy of the recommendation. And then if there's a case management agency that's involved, they will also get a copy. And if there's a home health agency involved, they will also get a copy. So if the home health agency submits the referral, the nurse assessor is going to send the recommendation both back to the home health agency and to the member themselves directly. That's a good one. Any other?
There's been a lot of questions about, from a case manager perspective, kind of the timeline. I think we don't know exactly what all of that looks like. We plan to have training available for case managers on that, but is there anything else you'd like to say in relation to, we typically do these 90 days in advance. How soon can I send a referral? Anything specific you want to speak to that? Or
yeah, it'll be similar to the current process that you utilize right now for Telegen. It'll just be on the front end. And so you'll send the referral. Yes, it could be up to 90 days in advance, 60 days, 30 days. Has to be a minimum of 30 days prior to that. We're ironing out those timelines. We really want to have some conversations with you all as case managers to see what's going to be most effective for you. And again, as Cassie mentioned, there will be training. We're working on that training specific for case managers to occur in May. But it'll obviously be posted, and we can do that multiple times as necessary too. Any other questions?
One more, Candace. I think this would be a good one. Megan asked if we can talk through an example with a July or August start date, continued stay review, and what that looks like, since the nurse assessor will not be executed and active at that point in time. Yeah,
so great question. And this is the difficulty of starting something, is you can't go too soon. There has to be a start date and an end date. And so for folks that are starting, let's say in August, there's certainly that 30-day time frame in July where there will be plenty of time to submit that referral. The July individuals, we're actually going to have a conversation with Telegen, the vendor, to see if we could walk through some of those assessments with them for maybe a handful of those folks. We haven't ironed that out yet, and what that looks like there, because obviously with their contract will be in effect, but the assessments don't technically start until July 1st on their own, but there's going to have to be some sort of training. And so for the July individuals, we will have those numbers in hand so that we can start to plan for that. But for August, it should be no problem to get those going and scheduled. We should be able to have them start intaking referrals before July 1 so they can start scheduling, like literally starting July 1. And as we iron out that contract and what that looks like, we'll have more information there.
Okay, sorry, one
You're
more
great.
that we saw in here a few times is who actually needs a level of care assessment by a case management agency? What scenarios does that apply to?
Great question. So a level of care assessment is going to be necessary for any member that might need to access services under Community First Choice, so CFC, or one of the current 10, well, it's going to go down to 9, HCBS waivers. So if an individual needs personal care services or homemaker services or in-home support services or CDOS, they will actually need to have access to CFC Community First Choice. Community First Choice is starting July 1. And so that timeline lines up with this here for anybody that needs those services that maybe doesn't qualify any longer for skilled care services. But all of those folks have to have the level of care assessment conducted by the case manager. All right, let's open it up for some verbal questions for folks. I want to make sure we have enough time to go through any other questions, have some ongoing conversation here. So I know we had a hand up much earlier, but I believe it looks like it went down. Who has a question that they'd like to ask live? Anybody want to ask a live question? There we go. Jim.
Hi. So for CDAS, does this assessment occur for everyone in July, or if I have a CSR, say in March, do we wait till that scheduled CSR for the assessment to occur?
Yes, that is correct. So you will wait until that scheduled CSR for that assessment to occur.
Thank you.
Absolutely. Great question. I saw another hand go up, but then it went back down. Laura.
Sorry, I was trying to unmute.
I totally understand.
In regards to that question that Jim asked, if a client has an end date later in the year but has a change in condition, will the change in condition be assessed on the current PAR and stay on the waiver, or can we take that opportunity to then move them over to CFC?
Yeah, you can take, so a change in condition will warrant an earliest assessment to move an individual over to CFC, and thus would need, if they have skilled care needs, trigger the referral process being necessary for the skilled care acuity assessment by the nurse assessor. Great question. Other questions? I know you guys have questions because I've been seeing them pop in chat the whole time. Jim.
I have another question. Is that, I see your timeline that you're given for this assessment, and based on my experience anyway, it seems really unrealistic to add another piece to the assessment process. It's multi-step. Took us 6 months to go through the last one. I think you need to really look at the timeline if you add this step for the assessment, maybe way earlier, 6 months earlier, maybe even. I think it takes a long time to go through this process.
Well, we haven't done it yet, so we don't have a frame of reference for how long it will or will not take. But I hear you. You want to make sure that there is enough time built in, and so we can certainly look at the timeline. But this will be conducted by a completely different agency that will be contractually required to meet the needs, and so it is not an additional step that is going to be required by a case manager or by the home health agency. The only piece that's additional is the referral, and then somebody else conducts the assessment piece there. But we can certainly take a look at the referral timeline for sure. Kristen.
Hey, I was wondering if for the vendor, Intelligent, do you have an idea of the ratio of nurse assessor to clients?
No, we don't have an idea. We did not put a requirement in. There is no ratio requirement. They are required to meet the needs. They knew what they were getting into. We provided them all the data so that they knew what they would have to be able to complete. But there's no specific ratio at this point in time.
Is there a time frame that they have to complete it by?
Yeah, there will be to complete the assessments by, yes.
Correct. Okay,
yeah.
Thanks.
Absolutely. All right, Amy, I think you were next.
Yeah, a couple of questions. Is there any requirement that nurse assessors be available in evenings and on weekends? for families who have busy schedules or parents who are working? Or is this just 9 to 5, Monday through Friday?
That's a great question. And that is something I will have to see if the team included that into the contract. I haven't, the contract is actually literally in my queue to look at, hopefully today. But they will be required to meet the needs of the families and the individuals. So more to come on that.
And can I add just one other plug?
Yes, of course, of course.
It would be wonderful if you could put this timeline into MSB rules. And I know at the last meeting you said we don't need to, or we don't always do this, but I think that would just to the transparency. You're going to have contracts that set it. Getting that an MSB rule just clarifies for everybody what the expectation is. So I'm just going to put a plug in for that.
Yeah, understood. I appreciate that. I think one of the issues that we run up against is the contract is still in progress right now, and the rules are going forward, at least for long-term home health. We're presenting those in April. And so we can certainly, if we find that we need to go back and add in, we can certainly have those conversations and do a lot of stakeholder engagement. But thank you for that. June, I saw you had your hand up, but it's now down. Did that answer your question?
No.
All right, what's your question?
Yeah, I have a few.
Okay.
If Essentra is getting those long-term home healths, are we getting those approvals? Because we are not seeing a lot of those approvals from Essentra being sent to us.
Can you clarify? Are you talking about for adult long-term home health?
Yeah, for adult long-term home.
So those don't go through the case management agency anymore. That it goes strictly through Essentra at this point in time. So
Yeah, I
you're
get
wanting.
that, but we don't see the approvals, so we don't know what got approved and what didn't. So it's causing problems because we don't know what was determined to be approved because we don't see those approvals.
Yeah, so that is something that we're working on. So that's always been the case for the children, as you know, because the children have always gone through that, and there's never been able to see the approval for what's approved there. And so we are working on a way that we can get case managers either a copy, access, something along those lines for all of them, because I understand from just a duplication standpoint alone, that's a really big deal, but also just to know as a case manager holistically everything that your member is receiving. And so we are working on that. So stay tuned and more to come. But that is something that is very, very much front of mind.
And then if a family member does not agree with the nursing assessor, the CMA sends the 803 saying that they're appealing the decision. Is that correct?
Not necessarily. So if the nurse assessor provides a recommendation that the member does not agree with, and we're talking health maintenance activities, if there is not justification to increase those hours beyond what the nurse assessor recommends, then yes, the case manager would send the 803. If there is justification for a differing of those hours, then the case manager can actually approve that going forward.
Okay. And then is the recommendation pretty much 100% guaranteed, or the case manager can determine if it's lower? Like if they say the nursing assessor says this many hours, but the case manager says it should be less, do we have to go off of what the nursing assessor says, or can we justify the lower amount?
So that's a great question. And I think the first time I've been asked that one, June. But, you know, if there is justification for it to be lower, let's say duplication of services, then yeah, you can go lower. You will just have to submit the 803 so that the member has the appeal rights.
And then, sorry, I have a few. It kind of, you mentioned in this on the PowerPoint, the 30 days prior that we send a referral for the nursing assessors.
Or more than that. It doesn't have to just be 30 days.
It could be more. But does the CSR need to be conducted prior to that referral, or can the referral happen prior to the assessment being conducted?
That's a good question, and a detail that I don't think we've ironed out just yet. I don't see a reason why it couldn't be either or. But I think more conversation around that with you guys, you case managers, could help us determine that.
Okay, last question. I have a
Okay.
few, but this is the last one. What if the nursing assessor can't get a hold of the client? The reason why I say that is because a lot of clients are comfortable with their case manager. When somebody else calls, they probably won't answer.
Mm-hmm. Yeah, so great question. And I think we'll have to come up with a mitigation strategy with the nurse assessor vendor, so with Telligent themselves, on how they're going to handle that. They'll likely have to go through the case manager themselves directly if they're comfortable and they have that relationship. Then they can utilize that relationship. A big component of this and a big important piece is going to be, especially for those members that have a lower comfort level, is for the case managers to provide that education on the front end. Say, hey, you are going to be outreached. You are going to be contacted. This is who's going to contact you, so that they understand the importance of it and the reason for that outreach. But if we get to that point, then we can hopefully work with the case manager to help the assessor with that.
Okay, that's it. Good to see you, Kim.
You too, June. Take care.
Bye.
All right, Katie.
Can you hear me?
I can.
Hooray, it worked. Thank you. I just had a question about the Acuity tool itself. I appreciate, I think you guys have posted another version of it that has more sort of boxes filled in, but I'm afraid it still doesn't give enough information to understand how it's scored. So like there's 2 columns for hours, which I don't know why there are 2 columns, and there's no indication of how points correspond to hours and like what's happening with the points to the hours. So we can't, I think the public just doesn't have a sense of how it's actually going to work because there's not enough information provided. So I was curious if you were planning to update that and what we can expect there. And then I was also just hoping you could talk more directly about what makes this tool reliable and validated and the process that you all went through, because I don't think that's been sort of talked about a lot. Thanks.
Sure. So I'm going to punt on a couple of those questions, Katie, because we really need to focus on the nurse assessor here, and the assessment tool itself is a whole different topic. So we will have trainings, information. We actually have a really cool video that was created to help assist in understanding how the assessment tool works that we can work on getting out. We have some 1-pagers that are available currently, but there will be a lot more information coming out about the assessment tool itself. And there is information online around how the tool was determined to be reliable and valid and what UMass did to create and then get to that point. And so all of that information is either online or will be online very soon. But as far as the focus of today, we're going to stick with the nurse assessor, but I appreciate the questions. Megan, looks like you were next in the queue.
Yeah, sorry, I haven't been able to keep up with the chat, so I don't think these have been answered. I have a lot of questions around the assessment process, what documentation will be there, and who will be there. I think, in many situations, the member or the member's family can give a really accurate, great picture of the member's needs to the nurse assessor to, collaboratively do that assessment. And I think there's a lot of situations where that is not the case, and there needs to be more support, whether that's from advocates or case managers or nurses that have worked with the family through their current home health agency or just other support people. And so I'm really curious what sort of documentation can be requested or will be requested outside of the family have to get provided, and or who else can be invited or is recommended to be invited to those meetings. That's one thing. And then also just wanted to say we've overall had fairly good experiences with Telligent, so I'm cautiously optimistic hearing that they have the contract.
Thank you, Megan. I will take your cautious optimism, and I am going to roll with that for the whole day. I just want you to know that, the whole day. So really, anybody can submit additional supplemental information as necessary. So, it's the home health agency absolutely can have the opportunity to support the member through clinical documentation. They have, if they are providing the referral, and they and actually it'd be recommended that they go ahead and provide supporting documentation, whether it's physicians orders, notes, nursing notes, things like that. out the gate. And then the member and family can absolutely request to have additional folks at the table for the assessment as well. And it can be an advocate, it can be the home health agency, it can be their nurse, it can be whomever, so that they can receive the most appropriate support as, you know, that they possibly can. And so that is really open-ended and going to be member specific, but there's not going to be limitations on who can provide the documentation and really who can be at the assessment with the member and with the family. So they can't conduct the assessment without the individual there, but they can certainly have other folks that know them there and able to help support and provide the information.
Can that be included in the training? Because, you know,
Yes.
like IEP meetings,
Yes.
it's the same thing. You can invite whoever you want, but most people don't realize that or realize the value. So I think
Yep.
there's a difference between you're able to and we highly recommend.
Yeah, great call. And absolutely, we can include that in the training. All right. Pam, you are up next. You're still
Oh,
on
here
mute.
we
There
go.
you go.
All right. Sorry. I guess my question, and I might have missed this because I've been doing like multitasking. But what right now we're sending all of this copious amount of information to Keepro, right? Or whatever it is now, through a Trizo, right? But when you're talking about the nurse assessor, like, are you saying that we're providing it to them then as opposed to like, or is the home health company still going to have to submit all of that same information exactly the way that it's being done now? I
Yeah,
just am curious how this stranger is going to walk into a home and truly understand, short of doing a head to toe assessment. Like, is she going to sit and read 300 pages of medical documentation? Like, and then we're also submitting that to this, to the state. And then, you know, this goes still to this physician. Like, cause I guess I'm really still having a hard time understanding how the nurse assessor and that piece of it fits into the process that's currently happening.
sure.
And who's receiving the information and how much time, you know, because when you have kids with complex medical needs, to correctly understand all these things, it's not a 5-minute conversation. To go through 30 days of nursing notes takes hours. So who's doing that if you're still asking us to provide that? And then where are we providing that information?
Sure. So the additional documentation is helpful for the nurse assessor to have, but it is not required of that process. The nurse is going to go out and conduct a clinical assessment of the individual. Their clinical staff, there will be a nurse that will conduct a valid and reliable assessment to determine the individual's needs. If there is additional documentation and information that is helpful for that nurse to conduct that assessment, great. If there is not, they're going to base it off of the actual assessment. So it's a nurse going out and conducting assessments, like a nurse coming in and conducting an assessment in a doctor's office or at the hospital, albeit different given the circumstances and the setting. But point being is it's still a nurse that's conducting those things, right? And understanding the clinical components and the clinical questions and how things play into each other. All of the documentation that is currently required will continue to be required via Essentra to conduct the full medical necessity evaluation. So Essentra and that process is the same. They are still the agency, they are still the vendor that is contracted to conduct medical necessity reviews and determine which services are medically necessary and at what rate. The nurse assessor is conducting the assessment piece on the front end to help with that information and to provide the education to members on the front end so they know where they can receive their services and what their options are out the gate.
Mm-hmm.
And it's to conduct one assessment instead of multiple, instead of having a CNA assessment and then also a PDN assessment by two different agencies. It's just one by one.
So, I mean, realistically speaking, the role in a child with complex medical cares for this woman to come out, or man, this nurse to come out and do basically a head to toe assessment similar to a start of care assessment.
Correct.
And then she's going to make a recommendation based on that, which really doesn't, like, I guess I just am curious. It's still very confusing to me. Like, I could say, okay, I'm going to send these assessment findings like in, yes, this child is this old and has this diagnosis, and I, auscultated their lungs and I listened to their bowel sounds, and they do have a G tube, and this is, the site appearance, and they do have a central line, and they do, all of these things. But to draw any further assumption without going through all of that medical information, and then they're making recommendations based on a fraction of the information, is still just very confusing to me, because it just seems like an extra step. You're having one person come out and basically say, okay, we saw the child. They do in fact have a G tube, and they are in fact non-ambulatory. But you're saying that they're also not going to review all of that information when you're considering these things, and then they're making a recommendation.
Yeah, so it's going to be similar to how the home health agency right now starts and writes their plan of care. They don't say that a child needs these services. That still has to come from
no,
a
it's the
physician.
doctor.
Yeah, exactly. So it's still, the services still have to be ordered, just to be clear. The nurse isn't doing anything like that. But there's the pediatric assessment tool that is conducted right now for CNA services. It's the same idea. It's just on a bigger scale.
Okay.
It's going to encompass all of the services instead of just CNA, and it is just one fraction. And so there are extraordinarily complex children that are going to need more than what is recommended. And that is where the additional documentation comes in, and the full medical necessity review comes in from Essentra.
Okay. Thank you.
Of course. Thank you. Erin, I see your hand up, so you must want to jump in.
I do. Hi, everyone. I'm Erin Thatcher. I'm the Participant Directed Program Supervisor. I wanted to chat a little bit about self-direction, IHSS, and CDAS, which is different than our long-term home health and private duty nursing processes. So Candace has shared how there's kind of two different pathways of, if you're getting a CNA service or PDN, you'll still need a medical necessity review from Essentra. That's going to stay the same. For people on CDAS or IHSS with health maintenance activities, the nurse assessor will come in, they'll do the assessment, and then that goes to the case manager, where the member and the case manager will work to like figure out what the care plan looks like. That recommendation is like critical in development of the care plan. Another piece of this is that we don't require orders for self-direction, and we don't require 45. Documentation is helpful. And if you've got it available, like I'm thinking about, asthma plans, seizure plans, feeding plans, all of that documentation we've got, in a folder someplace. If we've got that available during the nurse assessment, that'll be really helpful to ensure we get the services right. So just wanted to kind of delineate a little bit for our self-direction folks that don't have this high level of scrutiny and doctor's orders required.
Super helpful. Thank you, Erin. I appreciate that. And I was going to go to Nikki because she had her hand up. Before I go back to the slides, Nikki, did your question get answered? I'm going to go with yes. If not, please raise your hand again or put your question in the chat. Pam, did you still have your hand up, or did you re-raise it?
No, I'm good. Thank you.
Okay, great. All right, let's move on to the next slide so we can get through the rest of these. Appeals process. So this was another topic that we heard a lot about in our last meeting that people really wanted more information around. And so the appeal process, the HMA process first. So just to be clear, as Erin just dutifully noted, there are two different processes, if you will, and requirements around the health maintenance activities. So the self-direction services versus the long-term home health or private duty nursing services. So first and foremost, the health maintenance activities, HMA, that process outlined here. If the member doesn't agree with the recommendation from the nurse, they can actually supply the case manager with additional documentation to justify the request for additional hours. If the additional time is actually not justified and can't be supported through the documentation, then the case manager will notify the member and send them what's called a notice of action, or an 803, to that member. That 803, that notice of action, contains the appeal information so that a member can actually submit their appeal to the Office of Administrative Courts, and then the case management agency assumes the typical role in the appeal process. So that is the process and how it works for health maintenance activities. Next slide, please. And here's the process for private duty nursing and long-term home health. So if the member or the home health agency does not agree with the recommendation from the nurse assessor, and they think that the member needs additional hours, they can submit the prior authorization request for additional hours above the recommendation. The recommendation and the completed tool must be submitted with the prior authorization request, the PAR, along with the other required documentation and anything supplemental that can help justify the need for the additional hours. The utilization review contractor, or Centra, will take all of that information, the additional information submitted by the home health agency, along with the recommendation and physician's orders, all of the things. They will take all of that in-house to look at for the medical necessity review. If a Centra does not find that the hours are medically necessary, or the additional hours are medically necessary, a Centra is going to send the denial letter, just like they do now. The denial letter is going to contain the information for how the member can pursue options of the adverse determination, so how they can actually submit a formal appeal to the Office of Administrative Courts. So in the two instances, for health maintenance activities, the appeal information comes directly from the case management agency. For private duty nursing and long-term home health, the appeal information comes directly from a Centra, the utilization management agency that is conducting the medical necessity review, just like it is now. So for both or all three services, that is the exact process now, and that is the exact process going forward. That is not changing. So everybody will continue to have appeal rights, and the way that they receive those appeal rights will continue to be the same. All right, let's move on to the timeline, and then we have actually quite a bit of time for more questions. So here's the timeline for you all to see. It is a little nebulous as as things come up, and you all point out different things that we need to do. We're adding them in. So we added in the reading for the long-term home health rules. We're planning to have a meeting about once a month for stakeholders until this is launched, probably even through July, just so that we can continue to engage and provide information, answer questions, all of the things. So note that this will continue throughout July. So there's the timeline. Next slide, please. We went through these slides a lot faster than last time. So questions. Cassie, do you want to tell me if there's been any themes that I can answer out loud?
Why don't we go to the folks who have their hands raised, and I will cull through if there's some general themes.
Awesome. Perfect. Jim.
Thanks, Candace. Have you guys put forth a requirement for the nurse assessor? How long do they have to conduct after they meet with the family member? How much time do they have to finalize their assessment? Do they coordinate that assessment with us before they submit it to the case manager? What's the timeline you're giving them to get all this done and get the process done?
And so forgive me, do they coordinate with us? Who is us in this scenario?
Like the family member. I'm in CDAS, I guess the question is for
Okay.
CDAS. They do the assessment. Does the family member or the family, do they get to see that before they submit it to the case manager, or do they just submit it to the case manager and then we've got to work with the case manager not knowing, and see what they said? And what's the time, how long do they have to do the assessment and get it to the case manager?
Great. Okay. Thank you for clarifying that. So the timeline right now, like I said, we are working on the contract, but the timeline right now, we're looking at 7 days. So they will have 7 days from start to finish to get everything submitted and done. The recommendation will be provided to the family and to the case management agency at the same time. So you will each get a copy of it. So you won't have to go to them for the copy. You will receive a copy of the recommendation letter as well. Just like the home health agency will receive a copy of the recommendation letter, the case manager agency, but the member/family member will always also receive a copy of the recommendation.
Thanks, Candace. That helps. And I guess my last question on that is the way CDAS works is after we do get the PAR through the case manager's got to send it up for an independent review.
That is no longer going to happen. So that independent review is being replaced. So the independent review was by Telgen after the fact. That is being replaced because Telgen is conducting this assessment on the front end. So there will no longer be a second review for CDAS. That will need to happen.
That's good.
Yeah.
So I guess so in CDAS there's multiple, personal care and other making services. That still's got to be approved after the fact. I mean, the health maintenance part will be approved, but the other services, does that have to go for another review?
So that is all part of the case manager's process for submitting the prior authorization. So they will take the recommendation and all of that will go together in the prior authorization request or submission.
One last question.
Well, I have one last question.
Sure.
Can the case manager override the nursing assessor?
So can the case manager override? I think you
Yes.
talked about that.
Yeah.
Yeah.
And the answer is yes. As long as there is justification as to why it is necessary, then yes.
So there is still that final review for the other parts of it, though. So still the process is still going to be, because that part, it really takes a long time. And if I'm just trying to figure out.
There is no additional review after that process. So that part, so the way that it currently works is that once the case manager conducts their assessment and their prior authorization, they then send it to Telgen. And the reason for that review is to ensure that the appropriate level of services are being authorized, health maintenance versus personal care. That is being done on the front end. And so once the case manager is done with their prior authorization, there is no additional review after that.
Okay, thanks, Candace.
You're welcome. Thanks for the questions. All right, Sarah, you have your hand up.
Okay. I think for all of my RN friends on the call, one of my concerns, and I guess I'm just, bear with me thinking out loud here. I came into this world 3 years ago. I did not even know it existed. And this will be my 30th year of nursing. And so I think my concern is that hiring these RNs to come into this world and be ready to go in with that level of critical thinking between when they're getting hired, trained, and then starting off the blocks in July seems a very short window. And again, I may be the only one that feels that way, but I do feel like the concern from parents and others that are saying, how is this person going to come in and do this one assessment in this window and really understand the full picture, because learning that kind of critical thinking that is required for this patient population. And again, I'm talking pediatrics, but even as an adult with again, different needs. I just find it really hard to see how this isn't going to be real difficult for them and cause a lot of consternation for parents, families, thus wanting to do appeals, et cetera, et cetera. So,
okay, so that was a lot of questions, and thank you. I'm going to do my best to address them. So, and I'm going to start kind of all the way back. One of the key components that was required for the vendor to even be selected was they had to demonstrate that they were able to manage the work and have the experience. So the great thing about Telgen is they have been working with IHSS and CDAS, as a for example, for many years. And so they have a really good foundational understanding of what those benefits are, the nuances, the ins and outs of them. In addition, the assessments that are going to be conducted, those are, again, they're clinical assessments. This is completely within the norm of what a nurse typically does in any setting. They conduct a clinical assessment. And so it won't be outside of the realm there. And so we have complete confidence that the vendor is going to be able to bring in and have the appropriately trained individuals, nurses, to conduct these assessments. Nurses, again, this is well within your scope and your knowledge base to conduct these types of assessments. And it's like creating a plan of care. It's like creating an initial assessment for when you're intaking a patient. It's the same idea, and it's something that nurses do on a very regular basis. This program also actually exists in a couple other states. Kansas, as for example, they have this process with a nurse assessor, as does Florida. And then I think there's one or two others. And so this does exist in other states statewide and is working well in those states. And so we have complete confidence in our vendor to be able to do this. Kelly, you have your hand raised.
Yes, hi, Candace, can you just clarify when you said the nurse assessors have 7 days from start to finish? Is that 7 days from when they receive the referral, 7 days from the appointment with the family? Or individual?
Great clarifying question. I am phoning a friend to see if it is 7 days from the referral. Katie is going to help me out. Thank you, Katie.
Good morning, everybody. It's Katie Dobler. I'm the Clinical Operations Division Director, and I'll be operating the Nurse Advice Line contract. So they will have 7 business days from when the request was considered complete. Those of you who have any experience using any type of portal, there sometimes is an opportunity or a difficulty with submitting all the clinical documentation at the initial login. So there is going to be an opportunity for them to pend back to whoever is requesting the assessment to request for more information. So the 7-day timeline will start once all of the necessary assessment documentation is collected.
Is that 7 business days or 7 regular days?
7 business days, as I said before. And the reason why we chose 7 business days is because CMS is requiring us next year to move to a turnaround time of 7 days in most assessment portals.
Thank you, Katie. Donna, I saw your hand go up while Katie was talking, so I'm going to ask Katie to hang out. Well, she's been here the whole time, just so you guys know. But go ahead with your question.
Hi, Candace. Thank you. I just kind of want to go back to what Sarah was talking about with the nurse assessor and just, you know, that nurse maybe not having some of those skills in time. Not that they don't have the skills, but, you know, some of those nuances that are expected of them to be the person kind of making that recommendation. I also have concerns with the case managers because at the end of the day, they're going to be the ones that make that final decision. And I would say probably the majority of these case managers do not have a background, like a medical background, to actually make some of those determinations. So I don't know. I mean, I guess they'll have to lean very heavily on the nurse assessor's take on that. But, you know, if you could just speak to the sort of the logic in having them make that final decision, I'd appreciate it.
So the case managers are not making the final decision at all when it comes to long-term home health or private duty nursing. So the case managers are not determining those whatsoever. That all goes through the home health agency. And then there's a full medical necessity review that is conducted by Centra with nurses and physicians reviewing the information. So that is not going through the case manager. What is going through the case manager is the prior authorization request for consumer direction. And so consumer direction services, where you're talking CDOS or IHSS, are already case management, and they're already waivered services and things that case managers are very familiar with in authorizing for our members. And so I just want to make sure that that's very clear. The case manager are not making clinical authorizations. That all goes through Centra. And then the other component that I actually want to point out is we are also going to require that the nurses have background and education in providing this type of care. So we want nurses that understand what it's like to work with pediatrics. We want nurses that understand and have background in geriatric care, dementia care, all of the things, individuals with intellectual and developmental disabilities. So that is also a requirement as well. And we heard a lot of feedback from you all around that. And so we have actually incorporated that piece.
Thank you. I'm so sorry. I was referring to just the IHSS piece of it.
That's how it works now.
Yeah. Okay. Thank you.
Yeah, thank you. Okay, so I see a lot of hands raised, but really quick, I want to turn to Cassie to see if there's any themes in the chat that you want me to get to. And if not, I will go back to the hands. Happy to do that too.
There's several questions about, is there going to be a separate stakeholder meeting dedicated to the assessment tool, or will it be sprinkled throughout here? How can they get more information?
Sure. So as we're moving forward, we're working on exactly the flow of that. So we haven't identified exactly if we're going to mix it with one of these meetings, if we're going to have a specific one dedicated just to the assessment tool itself. More to come on that as we are moving forward with scheduling.
Great. One other one we got asked a few times is, will the nurse assessor actually participate in appeals? Will they support in that process, or will that be handled by Accenture and the case management agencies?
The appeals are going to be handled by the case management agency, Accenture, just like they are now, because that's where the appeal is coming from.
And one last one, I've seen this in here a couple of times. I did address it in the chat, but is there an AI who's reviewing this, or what is actually and who is actually reviewing these cases?
So there is no AI, hence my hesitation for even having a note taker AI. So the cases are reviewed at for medical necessity at a center for private duty nursing and long-term home health by actual people, individuals. There is no AI. They don't even own it. They don't utilize it whatsoever. Doesn't exist within the state of Colorado, within our contract. They're not allowed to use it. It is actual nurses who review, and then a physician, and sometimes multiple physicians, actually review each individual case. So thank you. But to clarify, no AI, period, like ever.
Thanks, Candace. I think they're kind of just some one-offs. We'll capture them in the listening log and respond there. I want to give the opportunity to those that still have their hands raised.
Great, thank you so much. All right, Pam, I see your hand up again. Pam just lowered her hand. Did you mean to come off mute? All right, if you still have a question or want to say something, go ahead and raise your hand back up again. Erica.
Hi, Candace. Thanks for taking my question. These meetings are super helpful, so appreciate HCPF putting them on.
Great.
If I understood Katie's response correctly about the 7-day timeline, the 7 days, it sounds like, starts from like the submission of the assessment. So my question is, what is the time frame from referral to the nurse assessor from the time the nurse assessor completes an assessment or
So
gets
the
out to provide the assessment?
The referral is the submission. Those are the same thing. And so once the point and the distinction that Katie was making is if they just get somebody's name, that's not a complete referral. They need some additional information as well. So it is from the time of the submission / referral, they have the 7 days.
7 days to meet with the patient and the family to complete the assessment?
Correct.
Okay. And then I just wanted to know if HCPF did any, like, where did the 7-day timeline come from?
CMS. Yeah, Centers for Medicare and Medicaid Services has a new standard for all assessment review and turnaround times, and it's 7 days.
Okay. And then did HCPF analyze any potential impact between the current process and timelines that occur versus the new 7-day timeline?
Oh, yes. Yeah, I mean,
Okay.
I mean, CMS is coming down with that, and that is something that the team has been reviewing and working on for quite some time.
Okay, it was just my understanding that the current timeline is that families are assessed as soon as possible, but within 24 hours, and that includes weekends. So what I heard her say is that it's business days, so it's 7 days.
It's not for the assessment. It's not to complete just the assessment, but it's also to have everything, the recommendation letter and everything out the door. So it's all of the components.
Got it. Okay, thank you so much.
You're welcome. All right, Pam, I see you raised your hand back up again, so I'm going to go ahead and call on you.
I'm good. You're good. Sorry.
Okay, cool. Megan.
All right. I hesitate to say this a little bit.
All right, let's do it.
I'm so pro participant directed programs. I think they're awesome. I love them. I'm excited to get to have more options for my kiddos for participant directed. That being said, there seems to be a huge gap between the amount of scrutiny that's going to be in place between long-term home health and PDN versus participant directed programs. That seems a bit inequitable, that if you're opting to use long-term home health or PDN, there needs to be all this clinical documentation, orders from the physician. There's going to be not only the nurse assessment, but also a review by a vendor, by like the vendor, that there's tons of scrutiny, versus for the participant directed, it's the nurse assessment and a case manager, they decide what they think is right and it's good to go. And I hesitate to say that because I don't want more scrutiny to be put on the participant directed programs, but I just wanted to point out the huge divide. And I think there's been some concern with community first choice, which again, I'm super excited about, but that there's a huge push towards pushing everyone into participant directed programs and making it more difficult to access things like PDN and long-term home health, that for many members is a better option. And I don't want people to feel like they have to choose participant directed, even if it's not the best fit, because the process is just laid out to make that the easier path.
Yeah, I hear you. And, specific to consumer directed attendant support, the Nurse Practice Act is actually waived in statute. And so by law, there are fewer requirements and around it to access that service. That is how it was designed, and that was intentional by our General Assembly. And so, there is a difference. Skilled care services must have an order. That is a license thing that is nationwide. That is not unique to Colorado. And so I hear you. And we will continue to have oversight of the participant directed programs. And, if we need to make some changes and make some alignments, we can certainly look at that. But we have faith in our case management agencies and having this assessment on the front end to help guide them, that it will all work out. But like I said, they are by design different services. Health maintenance activities are rarely provided by an actual licensed nurse. Other questions? There's no way I got through everybody's questions. I know for a fact I didn't, because there's a lot in the chat. I haven't even opened the chat, so to be clear, I know that there's no way I did. All right, I don't see any other hands raising. So I'm going to, Jude, go right ahead.
It seems to be that you're separating out the tool from the assessment, and I see them as directly related. The nurse assessment tool, the nurse's assessment, skilled assessment, will provide the data that's used to determine the members' allocation hours, and therefore services. And so if we're not talking about the actual tool, how the data is going to be used to determine the calculations for the end result of what we're all talking about here, when will we talk about that?
Yeah, understood. Great question and great point. And so they are intertwined, absolutely. And we will look to see And so we are going to have a stakeholder meeting every month, as I mentioned. And so we can look at that scheduling to determine when is the best time to kind of walk through that specifically. We were focusing more on the nurse assessor and the process first versus the tool itself, because in my experience, providing and doing it all at once is a 5-hour meeting, and I don't think I can sit still for 5 hours, full disclosure. But it's a lot for both us to present on at once and for everybody to absorb at once. And so that is the reason for the separating it out and not combining it all at once. But your point is extremely well made, and taken, that they are very reliant on each other, 100%.
I mean, it's what you're doing the assessment for, to determine the budget for the member. And so when we get, there's all this time frames and the process and the flow, I understand. But when you get to the actual data collection, that's when we have to start looking at how the numbers work. And so if there is a plan for that before the month before, I mean, those of us that deal in numbers are quite antsy about how the numbers are going to work. I know a lot of people have to be focused on the process, and that's good, but there's some of us that are numbers nerds, and we want to see how the numbers are going to work.
Yeah, totally fair. It's all posted right now, and we will certainly plan to have that as a topic.
But you can't figure out the numbers from looking at it.
Okay, so we will plan to have that as a topic before June.
Okay, thanks.
Yeah, of course. Thank you for the question. Can you go to the next slide for me, please? There we go. Okay, I just wanted to have this up so folks could see the email. I see you have your hand raised.
Hi, I know you went over this a couple times, but I just wanted to clarify. So when you get the referral, they have 7 business days to get out there and actually do the assessment, correct?
They have 7 business days to get out, do the assessment, complete the assessment, and provide the recommendation letter.
Okay, so when they meet with the family, do they give them any idea of what they're recommending or what they're gonna say they qualify for?
Yeah, so that's a really important piece, and thank you for that question. So a big component of the nurse assessor is actually the education piece. So as they are conducting the assessment and going through all of the needs of the member, they're going to be able to tell you, not definitively 100% necessarily every single time, but they're going to be able to say, hey, it looks like you have a need for a nurse, or these needs actually can be met via a certified nursing assistant, a CNA, or there's really not any skilled care needs that are identified. They all can be met at the level of a personal care. And then they're going to be able to provide the information on the different ways. So if you have a need for a nurse, they're going to be able to explain to this person how they can get those needs met at that level. And so the family should have an idea during the meeting itself what they will qualify for.
So what happens in the event that they tell them that, yes, it looks like you do need a nurse, and then a packet gets submitted to KeyPro and then KeyPro denies it? What happens in those kind of situations?
Yeah, so those are then going to be clearly the information was not provided by the home health agency. And those are situations where we would need to provide some pretty clear technical assistance to the agency so that they can understand what is required and what they should be submitting. So the only reason that a nurse conducts this assessment and then the services, unless there's a drastic improvement, those services aren't deemed medically necessary. So there's no supporting documentation. There has to be orders, there has to be a plan of care, there has to be all of those things as well.
Okay, thank you.
Of course. All right, I'm going to take Pam's question and then we're going to move on to next steps because we have 4 minutes left and I want to make sure you all have all of the information. Go ahead, Pam.
I was just wondering, when you said earlier that it was 7 days from when you guys deemed the application complete, what is going to be requested for that specifically?
Sure. I don't have the answer to that yet. We are working on that. But all of that information will be very clear and public, and everybody will know exactly what it will take to have a referral complete. So whether it's 3 things, the name, the number, and the diagnosis, or the name, the number, I don't know. I'm just making things up at this point.
Well, I
that will
just
be-
asked because you're
that will-
giving it 30 to 45 days. And right now, like, for instance, we submitted information on one of my kids, right? And they wanted 30 days of nursing notes, which just seems to be standard these days. However, then they wanted 30 more days outside of the actual recertification period, right? And so this went on for 60 days. To
Yeah,
the
so
point where we're not
you're talking
getting
about the
payment anymore and
utilization
we're still in
review,
it.
right?
But my concern is the exact same thing's going to happen. And we're going to run into these huge, oh, you didn't provide us this, or oh, we need this, or oh, like this says this, so we need X amount. Like I've been sitting waiting for, the hospital to amend records so that they matched their other records, so that because every single time we send something that doesn't match X, Y, and Z, even though we have no control over it, it's being sent back, and then it's being delayed another 10 days, and then we're sending back, and then they're asking for more. And so I'm just afraid that it's going to be like when you say that and there's specific information that that amount of time isn't going to be enough, because if that gets delayed past the 30 to 45 days, now we're still waiting on that. Plus then we have to go through the other process that seems to be like a 30 to 60 day laborious process, no matter what you send the first time.
Yeah,
So
the requirements are
just
not going to be that stringent. The requirements are not that stringent for the nurse assessor. It's going to be really basic information that will allow the nurse assessor to contact and go out and conduct the assessment. They are not requiring the additional documentation. It could be helpful, but it is not required. It is required for the vendor to be able to conduct a medical necessity review. In order to fully complete a medical necessity review, they have to have that information. They have to be able to look at it all. But I hear
I
your point, and
recognize that. I'm just worried that you're putting
hear you.
another process that can turn like in front of that process that could turn into the like same thing that then is going to, now we're looking at, instead of 30 to 60 days, we're looking at 60 to 90 days while we sit, like, you know what I'm saying? Because
Yeah,
we
so
didn't
there's
get
gonna
X
be-
done by the right period of time because we couldn't, get whatever they wanted. You know what I'm saying? Like,
Yeah.
that's my concern, is that
I
it's
hear you,
just
but Pam,
gonna
we're now out of
further.
time. We're now out of
Yep.
time. I need you to pause for me, please. I hear you. I hear your concern. We will absolutely address it. We will make it very clear with the nurse assessor what the requirements are to submit a referral. It'll be very minimal. There's not going to be the pending for 60 days unless somebody just doesn't, submit the 3 things that are going to be necessary. It is not going to be this back and forth for, a long time. It is a very minimal process and amount of information is going to be needed to submit the referral. It is completely different than the medical necessity review. So with that, I'm going to move on to, there is the email there on that slide. If you have additional questions that you would like to submit to us, please send it directly to that email box. We are working on scheduling our next meeting, which will be in April for this. Please also submit topic ideas. So things specifically, I heard everybody wants to go over the assessment pretty clearly and the scoring and all of the things there. So if there are additional topics that people would like for us to cover, please submit those to that inbox as well. This slideshow, this recording, and the chat will all be available online. The chat we are going to copy and we're going to provide responses to every single question, and we will post that just like we did from last month's. I want to thank everybody for attending. This was a full hour and a half of your Tuesday, the first week after daylight savings. So we're all exhausted because none of us are sleeping well. I know that. But thank you guys so much for joining, for asking the great questions, and for your time and your participation. And I look forward to seeing you next month. Thank you guys. Take care.